Assalamu alaikum wa rahmatullah, everybody. Thank you so much for joining the 41st Libyan cardiovascular webinar, titled with the atrial fibrillation, stroke prevention, part 1 stroke prevention. This presentation will be joined by my friends and colleagues, Dr. Khalid Bouzgaia from the United Kingdom and Dr. Yusuf Barat from the USA, Kentucky. Both are cardiologists and physiologists. So the presentation will be interactive. We try to make it as practical as possible, and would like to have some interaction on from the audience. Any questions can be put to the Facebook page. We will watch them and we will try to apply them as this presentation goes. So can you move the slide there for me? For some reason I don't. Okay, so we'll start by a case. This is Nancy. She's an 82-year-old female. She has history of hypertension, diabetes, and she has history of paroxysmal atrial fibrillation. However, she is very active. As you can see, she exercises regularly. She is very healthy and active. And the question for her paroxysmal atrial fibrillation, do you want to put this lady on oral anticoagulation, blood thinners, or you would not? So if somebody can type in yes or no as an answer, but we will come to the story of this lady a little bit later. The next slide, please. So, okay, yeah, now I have a control slide, perfect. So atrial fibrillation is the most common sustained arrhythmia ever. As you know, atrial fibrillation essentially can be classified into three main ones: paroxysmal atrial fibrillation, persistent atrial fibrillation, as well as permanent atrial fibrillation. You also can classify atrial fibrillation to valvular atrial fibrillation, and this is essentially limited to patients with mitral stenosis or patient on mechanical valve in the mitral position, or non-valvular atrial fibrillation. Today, most of the discussion will be based on the non-valvular atrial fibrillation, because we know valvular atrial fibrillation is a high risk for stroke, and all patients need to be on anticoagulation. The main issue with atrial fibrillation, as you know, is it has a 5-fold increased risk of stroke, and atrial fibrillation is responsible for about 20 to 30% of all stroke. So it's a big health issue, and stroke has major implications on the patient's outcome, morbidity, and mortality. So the question is, who do we need to prevent stroke in? What kind of rhythm, what kind of patients? And this is the core of the discussion today. So there will be simple answers, but will be a complicated discussion. So number one, all forms of atrial fibrillation, paroxysmal, permanent, persistent, it doesn't matter. All of them needs to be subjected to the assessment for stroke prevention. Number two, all valvular atrial fibrillation, as I just mentioned, are high risk and need to be on anticoagulation. At this time, warfarin is the only agent you can use for patients with valvular atrial fibrillation to prevent stroke, like mitral stenosis or a patient with mechanical mitral valve. For non-valvular atrial fibrillation, the question is to use oral anticoagulation versus other agents. It depends on the benefit-risk ratio, the benefit on preventing stroke versus the risk of bleeding. And for that, we need to assess the patient using a risk of embolic risk, for which case we use a CHAS-2-VASc risk score. And also we need to assess the risk of bleeding, for which we use the has-bled score. So I'll probably ask Dr. Yusuf Barat to take over and tell us more about the risk assessment for patient atrial fibrillation Yusuf, can you comment about that?
Assalamu alaikum. Thanks, Fathi. Let's start my video. Let's go to the next slide. So, thanks for joining us today, and part one of the AF Symposium. As mentioned.
So, Yusuf, I can't hear you. Can you speak a bit louder?
Yes. So, can you hear me better now?
Yeah, it's better now.
Thanks for joining us today in the first part of the AF Symposium. The main focus today is to talk about anticoagulation and stroke prevention and atrial fibrillation. And to do that, it's really important to risk stratify patients to decide which patient is a candidate for anticoagulation, since we know that there's a risk benefit balance. So there's risk of bleeding if you start an anticoagulant versus risk of stroke if the patient is not on an appropriate anticoagulation to prevent stroke. So in order to do that, it's essential to know the CHADS score and the CHADS VAS score. I'm sure that all of you are familiar with CHADS score, which has been around for years, and it's based on risk factors for increased stroke, well-validated stroke or score system. Point number one is congestive heart failure. So any history of congestive heart failure, symptoms of congestive heart failure, we give 1 point. Hypertension would be any risk of any history of hypertension, whether it's treated or blood pressure above 140/80. Age above 75 is 1 point. Diabetes is 1 point. And then, of course, if there's a history of stroke or TIA, previous thromboembolism, then definitely the patient needs an anticoagulant. So a CHAD, based on this, a CHADS VAS score of 2, there's indication for anticoagulation. 1 that can be discussed with the patient. CHADS score of 0, there's no need for anticoagulation. Now, recently, that was first introduced in Europe, we've had the CHADS VAS score system. We've been using it since 2014, at least in the US, based on the guidelines. It's recommended, it's the recommended scoring system to risk stratify patients with AFib. And so the same thing, kind of similar, except that we add vascular disease, we give it 1 point. Age 65 to 74 years is 1 point, and female sex is 1 point. We know that females are at higher risk of stroke, and therefore it's considered as a risk factor, therefore they're given 1 point. Here, the difference is that age above 75, we give 2 points rather than 1 point compared to CHADS score system. And of course, the higher the CHADS VAS score, the higher is the risk of stroke. We'll move on to the next. On the other hand, what about risk stratifying for bleeding? So we have a HAS blood score, another validated scoring system. Uncontrolled hypertension and blood pressure above 160 is given 1 point.
Yusuf, can you speak a little bit louder?
Abnormal kidney or hepatic function, whether it's abnormal liver enzyme or kidney disease, it's given 1 or 2 points. And then stroke, 1 point. Bleeding history or anemia is 1 point. And labile INR, when the INR is variable and then the therapeutic range is less than 60% of time, meaning that INR can be low and can be high, then that's 1 point. And elderly patients above 75, that's another point. If the patient is an antiplatelets or NSAIDs or alcohol, or there's a history of alcohol abuse, then there's also points given. So based on that, if it's above 3, then that's considered as increased risk of stroke, or increased risk of bleeding, I'm sorry, intracranial bleeding or bleeding in general. There's an app that can be used. Also, American College of Cardiology has an app. There's an app that you can download on your cell phone, and you can put the patient risk, give you either the HAS blood score or the CHADS VAS score, and based on that, you can risk stratify the patient and decide whether the patient is a good candidate for anticoagulation or not. And so based on the guidelines and based on CHADS VAS score, like I said, we mostly use CHADS VAS score now. If the CHADS VAS score is 0, we don't do anything. We don't give aspirin or antiplatelet therapy or even or DOAC or warfarin. Then a CHADS VAS score of 1 that can be discussed with the patient. You can, I mean, the American guidelines do mention that aspirin can be considered. In the European guidelines, aspirin actually is a class 3, so it's not really indicated. I generally don't give anticoagulation if it's CHADS VAS score of 1, but that can be discussed with the patient. Risk of stroke versus risk of bleeding can be discussed with the patient. If the patient is low risk and they're worried about stroke, some patients say, well, I have a family history of stroke, it's reasonable. Then 2 or above, of course, it's indicated, given that the bleeding risk is low. So you can calculate Has blood score if the patient has a low Has blood score and they accept anticoagulation, then yes. Also, it's really important to check kidney function, particularly if you're starting the patient on a DOAC. So that's kind of a summary of starting the patient on anticoagulation based on the CHADS VAS score. Next slide, I'll have Khalid, Dr. Bouzgaia, take over from here. Khalid, you're available?
Yeah, you should be available.
Thank you, Yusuf. Can you hear me now?
Yes, we can hear you, Khalid.
Excellent. So yeah, so there's different options of oral anticoagulations. The conventional way, which is vitamin K antagonist, such as warfarin or Coumadin. Also, there is agents, we used to call them new oral anticoagulant as NOAC, but they no longer new, and now we call them DOAC. The D stand for direct oral anticoagulant. And there is different medication available in the market, such as the Bigatran, Rivaroxaban, Apixaban, and Aduxaban. We'll come to discuss this in more details later on. So I'll go to the next slide.
Yusuf, you probably can move the slide for Khalid or give him control.
Excellent. So this is really important slide to explain the coagulation cascade. As we know, in the left side of the screen, you could see the intrinsic pathway, and on the right side of the screen is the extrinsic pathway. What's interesting here is the vitamin K antagonist. You could see that it affects multiple steps in the cascade. And this is why warfarin Coumadin has a very narrow therapeutic range and with lots of interaction, such as drug interaction, food interaction. Whereas the new class of the medication, they are so specific to one step in the cascade. For example, a factor 10A inhibitor, such as Apixaban, Rivaroxaban, and the new agent Aduxaban, affect number 10A, and the Bigatran, which is direct thrombin inhibitor. So these medications are so specific, and this is why they don't need monitoring, and there is less interaction with other medication. So this is really important. We'll discuss that in the next slide, I think. Next slide, Yusuf, please. So just to recap on the evidence about these medication, what we call them DOAC. The first study was the RELY study, where the Bigatran was used in an open label fashion. This is a twice medication. They use 2 doses, a low dose at 115 milligram twice a day, and a higher dose at 150 milligram twice a day. This was between 2009 2010. And then the second study, which was the Rocket AF, where they looked at Rivaroxaban, which is a factor 10A inhibitor, This was a double-blinded study where, again, they examined 2 doses. So they usually tend to use the reduced dose for higher risk patient like renal impairment or slight increased risk of bleeding and elderly and low weight. And the lower dose was 15 milligram, whereas the standard dose was 20 milligram once a day. And then the third study, which was the Averroes. The apixaban has 2 major studies, the Averroes and the Arstitol. And again, they tested 2 doses, the reduced dose 2.5 twice a day versus the full dose of 5 milligram twice a day. And the final study, which was published in 2014, looking at edoxaban, which is the latest medications in the direct oral anticoagulant agent, which was again double-blinded, examining 2 doses, the reduced dose of 30 milligram once a day and the full dose of 60 milligram once a day. And it's interestingly, all of these studies showed that these medications have favorable effect and was non-inferior to warfarin. We will go in some details, but the message is most of these medications were non-inferior to warfarin with less risk of bleeding. And the advantage, obviously, with this medication, you don't need blood monitoring and there is less drug interaction. So we'll go to the next slide. So this is just to compare the warfarin, the vitamin K antagonist versus the direct oral anticoagulant agent. Interestingly, the onset of this medication is rapid as compared to warfarin. It tend to be, most of them have a short half-life. The key and the most attractive feature of these agents is you don't have to monitor them, whereas for the warfarin, we know it has a narrow therapeutic range, ideally between 2 to 3.5 and variable on the indication, whereas these medication, they don't require blood monitoring. Obviously, the main limitation of warfarin and the inconvenience for patient that you have to dose, it has to change according to the blood test, the INR result, whereas the new and the direct agents, they are fixed dose. It depends on the risk factor, whether they should go on the reduced dose or the full dose. The warfarin, we're aware that has many interaction, whether is it food or drug, whereas these direct agents, they don't have as much as interaction with food or drug. The only exceptions is the rivaroxaban. It's encouraged to be taken with food for pharmacokinetic and absorption, otherwise it will not be effective. One of the main limitations of this drug when they came out to the market, that there was concern about the risk of bleeding and antidote and reversal agent. But we know now that there is an agent for the bigatran, which has been available for a couple of years. And there is just been FDA approved recently, a new agent for anti-10A factor. So for example, for apixaban, rivaroxaban, and edoxaban, now there is a new agent which is proven to be effective antidote and reversal agent. So overall, as you could see from this table, there is several advantages of these direct oral anticoagulant agents as compared to the warfarin. And we'll come to discuss that more in details in the next few slides. Next slide. So now I'll hand you over back to Dr. Fathi Idris Ali.
Shukran, Khalid. So we'll take a case and try to apply some of these principles to it. Mr. MG is a 63-year-old male. He's otherwise healthy. He complains of palpitations for 2 months. He comes to your office. You do an EKG on him, and his EKG, sure enough, shows atrial fibrillation. He's otherwise stable hemodynamically. His heart rate is 98. His blood pressure is 118/64. And next slide. He then this is the summary of his profile. So for this patient who has only history of atrial fibrillation, he's 63 years old male, and he's not taking any medication. So what would you do for this patient? So I want you to write your answer, 1, 2, 3, 4, 5, in the Facebook chat page. And we'll go over this case. Mr. MG will be with us till the end of this presentation. So, and it's a theoretical case, so we just need to use it as a practice to calculate risk assessment as explained by Dr. Darat earlier for CHATS to VASC and has bled. So type in what do you do for Mr. MG? Would you do nothing? You give him nothing. You know his atrial fibrillation is rate control, or you give him aspirin. Third choice is give him aspirin and Plavix or clopidogrel. And fourth choice, you put him on warfarin, or you put him on the DOACs or NOACs, which are the medication just explained earlier by Dr. Khalid. So we'll give people a few seconds to response. So Dr. Abdulwahab Naas answered number 1, means do nothing. Okay, that's great. We'll wait to see if some more people has input on this. And yeah, Dr. Khalid Khmaj answers 1 or A. I assume he means 1. Okay, great. So Yusuf, why don't you tell us what would you do for this patient for risk assessment?
Okay. So, yeah, I mean, this patient's CHATS VASC score, as we discussed, is 0, based on the absence of any risk factors. Again, as we mentioned, no congestive heart failure, no hypertension. He's below 65, no diabetes, no history of stroke, no vascular disease, and of course he's a male, and therefore his CHATS VASC score is 0. His HAS-BLED score happens also to be 0, but in my opinion, and based on the guidelines, of course, he does not need any anticoagulant, not even aspirin. So I would not give him any anticoagulation. So as we said, the CHATS VASC score is 0, so he has a low risk of stroke. Benefits from aspirin have not been conclusively shown in these patients, and therefore no antidepressant are needed, and likely the risk is, you know, of antithrombotics is more than a benefit. So if you give the patient aspirin, there might be increased risk of bleeding, or you give him anticoagulant, there's going to be increased risk of bleeding, and no benefit of preventing stroke. Okay, Fathi, any questions about this? I think it's kind of pretty straightforward. This is our baseline. Okay. Score 0, yeah.
Great, thanks, Khalid. So Mr. MG comes to see you about 4 years later. He doesn't come to the doctor very often, obviously. So 4 years later, he comes to see you. You do an EKG on him, and he's still in atrial fibrillation. So next slide. So this is Mr. MG's risk profile now. The only difference from before, now he's 67 years old. It's highlighted in brown color. And nothing else changed, no medical history changed, no medication changed. So at this time, Mr. Green will ask you about what you do for him. Would you do nothing? Give aspirin, clopidogrel, warfarin, or DOAC? So please go ahead and key in your response to what would you do, which choice for Mr. Green at this time. And we'll give audience about a few seconds, and then Khalid will tell us what. So Dr. Ali Maddah, he answers 2. You give him aspirin. Great. Just waiting for a couple of at least more responses. And so the only difference now, he's 67 years old. Okay, Khalid, can you tell us what would you do for this patient based on evidence we have so far?
Right, okay, we'll go to the next slide. So here, clearly his CHATS VASC score is 1 based on age. However, his HAS-BLED score is still low at 0. So this is where there is slight variation of the practice across the Atlantic. So if we could go to the next slide. So the choices here is whether we should do nothing and give nothing, whether we should consider giving oral anticoagulation or we should give aspirin. So with regard to the European and UK practice, aspirin is no longer recommended for CHAD VASCOR 1, but anticoagulation should be considered and discussed with the patient. Whereas the AHA, ACC, HRS guidelines in America that you may consider aspirin. So in this situation there is slight variation, but the overall is you could discuss anticoagulation as an option. This is European practice. Whereas in America, you could discuss that or consider even aspirin. So the European guideline, which was only published in 2016 and updated 2017, clearly classify aspirin here as class 3, which basically you should avoid. However, I think, Fathi, correct me if I'm wrong, in America, you still can consider it after discussion with patient. Is that correct?
That's right. So based on 2014 guidelines, which are the latest we have in the US, is aspirin is still a consideration, but there's lots of practice variation. Some people use it, others don't use it, so it's still in the choice. I suspect the newer guidelines will take it off probably because, as we can see, the impact of aspirin, relative risk reduction, especially in a very low risk patient like this, is no data, no significant data.
I agree.
And higher chance to risk score, there may be some evidence. So, very good.
So I personally, for this patient, with this patient, I will discuss that his risk is kind of relatively low. However, anticoagulations, I will discuss the benefit and risk. And then this is a situation where I make the decision with the patient, either anticoagulation or not. So if we could go to the next slide.
If you may, I'll just add one thing based on what you mentioned. The level of evidence is class C, which is consensus. So there, as you mentioned, there's no data to support it. It's just consensus among the guideline writers. And class 2B, so it's really weak.
Yeah. So next slide. Right, so back to you.
Great, thanks, Fad. So now, 3 years later, Mr. MG is doing well, but he's still in atrial fibrillation. He had a stent put to his right iliac artery about 2 months ago. He developed arthritis, and now he's put on non-steroidal anti-inflammatory agents. And he also developed diabetes, and he's now put on metformin. So in just 3 years, Mr. MG started falling apart. He started having multiple health problems, and so now he developed peripheral vascular disease. He developed arthritis. He's on non-steroidal. He's developed diabetes. He's on metformin. And also there was a comment by Dr. Abdulwahab Naz about screening those patients for diabetes, which is an excellent comment. So again, the point is that you need to evaluate your patient for risk prevention periodically. Every time they come to your office, you need to reevaluate them for risk of stroke, risk of bleeding. So Yusuf, what would we do with this patient at this time? Let's move to his profile now. Next slide, please. So the changes since the last visit are put in an orange color. So he's now 70 years old. He has permanent atrial fibrillation. He has arthritis, peripheral arterial disease, and diabetes as medical history. He now has medications, non-steroidal metformin. So at this time, what would you do for him? Would you give him nothing? Aspirin, aspirin Plavix, warfarin, DOAX. So please type in your best choice. Again, you need to calculate your risk score, etc., quickly, and then type in what would you do for this patient at this time. We'll give a few seconds for people on Facebook to respond to this. Okay, so Dr. Ali Maddah for warfarin, that's great. Dr. Khalid Khamash, 5 DOACs. Great. Okay, so people now start putting those patients on oral anticoagulation. Great answers. Okay, what should we do, Yusuf, then?
Yeah. So we'll, one step at a time. So like you mentioned, we'll calculate the CHA2DS2-VASc score first. And based on the patient's risk factor, number one, he's 70 years old, so above 65, we give 1 point. The patient had a right iliac artery stent, and so therefore he has peripheral vascular disease, and therefore that's 1 point based on the CHA2DS2-VASc score system. And then diabetes, that's another point. So the total CHA2DS2-VASc is 3. On the other hand, his HAS-BLED score is not high. Age, that's 1 point above 70, above 65 should be 1 point. And the use of NSAID, which for his arthritis, so that may increase risk of bleeding, specifically GI bleeding. And so his HAS-BLED score is 2. Therefore, it's reasonable and actually indicated to start patient on warfarin or DOACs. And therefore, both answers are correct. Ali and Khalid and Abdul, it's the correct. Warfarin, DOACs can be used. So option 1, warfarin. So warfarin, based on studies that were done in the 80s and 90s, compared to aspirin or placebo in certain studies, has shown significant risk reduction. 2 to 7% relative risk reduction, and therefore we know that warfarin is better than aspirin in reducing stroke. Aspirin itself does reduce relative risk in antiplatelet versus placebo stroke, but it's not as good as warfarin, and therefore, especially in patients with a CHA2DS2-VASc score 3, they were extensively studied. I would prefer to use anticoagulant, like I said, warfarin, or recently one of the DOACs, and I'll have Khalid take over from here, but DOACs, as Khalid mentioned, are been, based on non-inferiority trials, been shown as effective as warfarin. So Khalid, go ahead. And
yeah, Yusuf, clearly this slide, if you could see the slide, this clearly showed that all the major 4 study looking at the DOAC showed that they have a favorable impact on the reducing risk of stroke and systemic emboli event as compared to warfarin. And even the combined effect model clearly favor the use of DOAC. And the next slide will clearly show that even the risk of bleeding is significantly less in most DOAC. The Rocket F kind of was neutral or similar to the risk of warfarin. So essentially we have these new agents where they have a favorable effect on reducing the risk of stroke with less risk of bleeding as compared to warfarin. And obviously there is less risk of drug interaction, food interaction, and there is no need for monitoring. So these medications has proven to be more favorable as compared to warfarin and becoming more popular. And in my practice, and I'm sure, I don't know, Fatih and Yusuf, if you agree, it's almost become a gold standard unless obviously there is contraindication.
Okay, very good. So the patients chose, so they decide to discuss the options with the patient. So they told them, you can choose warfarin or you can choose DOACs. And the patient could not afford the DOACs at that time, so said, well, I'm going to go with the warfarin. So the patient was started on warfarin as the choice, yeah. And I see some comments about this being expensive, which is, again, something we can discuss later on. So the patient was started on warfarin. Can we move to next slide, Yusuf? So now it's 5 years later. Clearly, Mr. MG doesn't see the doctors quite regularly. So it's 5 years later, he comes to the emergency department with transient dysarthria, and he has a right-sided weakness. For 6 hours, that resolves spontaneously. So the clinical presentation is comparable with a TIA. His blood pressure was stable, 135/80. His pulse is 82, still atrial fibrillation. You did a CT scan on his head. It's negative. It doesn't show any major bleed or stroke. But we know the CT scan initially can be negative for the first couple of days. And his INR is 1.7. And we know for therapeutic INR, you have to be higher than 2. So, and then you check on his recent blood work from his family. They tell you his last INRs were 2.2, 1.1, 4.6, and 1.6. So clearly he swings back and forth. At times he's subtherapeutic, his INR 1.1 or 1.6, and at times he's super therapeutic with INR is 4.6. And that's what we call a labile INR. So Khalid, or actually Yusuf, at this time, let's review his profile. So he's 75 years old. He's older now. He's, in addition to permanent AFib, arthritis, diabetes, PAD, he now has history of hypertension, and he has stroke, CVA. New medication now are lisinopril, and he's on Coumadin labile INR. So at this time, what would you do to this patient? You keep him on warfarin, target INR 2 to 3, same as before, meaning change nothing, or you target higher INR. So say he stroked on an INR of 1.6, so we'll make it INR 3 to 3.5. So target a higher INR, or you put the patient on aspirin, Plavix, clopidogrel, or you reduce the dose of warfarin and put the patient on aspirin. So use a lower dose INR, but add aspirin on top of that, or you just switch him to DOAC, switch him to one of the newer agents. So start seeing some answers. Dr. Ayn Maddah chose number 5. Great, excellent. Give it probably 10, 15 more seconds for people to catch up on Facebook and give us answers. And one of you guys will tackle this. Maybe we can tackle this. And there is a question also from the people who joined us on Zoom. So probably we'll come to this later. 4, low dose. Okay, so there's somebody chose low dose aspirin, low dose warfarin and aspirin. Choice is 5, if not affordable, 2. 2 means warfarin, target INR 3 to 3.5, so higher therapeutic INR. So that's very good points, excellent points. So let's move on to the answer. Yusuf, what would you do? Let's calculate. Again, the point is to calculate the patient's risk for bleeding and stroke. Every time he comes to you, you need to sit down and recalculate the whole risk. Go ahead, Yusuf.
Okay. So again, Chad's VAS score here based on age. He's 75, so we'll give him 2 points. Peripheral artery disease, 1 point. Diabetes, 1 point. Hypertension, 1 point. And he had a stroke, so that's 2 points. So it adds up to 7. Has blood score is 3 based on age, NSAID used, and his labile INR. So we're starting to become more significant risk of bleeding. So the options here, I mean, this gentleman has INR all over the place, anywhere between 1.7 to 4. And so as you can see here, let me put, there's a pointer. So this is one of the really nice slide that shows the relation between INR levels and risk of thromboembolism and intracranial bleed specifically. And patients with INRs below 1.8, they have a higher risk of thromboembolism. Actually, the risk of thromboembolism becomes lower between 1.8 and above, actually. While on the other hand, risk of bleeding increases above 3. So that's why we really choose an INR goal of 2 to 3. Now, this gentleman, his INR has been all over the place. It's been less than 1.7, and so that's why he had risk of bleeding, risk of stroke. So therefore, in this instance, DOAC
Can you go back, Yusuf, to the slide again, just to
yeah.
Because And on the right side, again, if you increase his INR between 3 to 3.5, you get no benefit in terms of stroke reduction.
Exactly.
But the bleeding risk goes very high in the blue. The bleeding risk is blue, stroke prevention is flat in red, right? So that's very clear there.
Yeah, no additional benefit, and like you said, intracranial.
Exactly.
So based on this, I mean, someone with a labile INR, a DOAC would be better, given that the patient, of course, uses the DOAC and has good compliance. And so it's been shown actually that, for example, apixaban has been associated with less risk of bleeding compared to warfarin. So that can be an option in this patient. Here, I'll have you take over, Fathi. I was thinking kind of more apixaban, but you take over.
Great, thank you. So, so Mr. Green admitted that he's non-compliant with taking his warfarin, so he takes a few days. Other days he doesn't take it. So warfarin was discontinued as suggested by you, and the patient started on the Bigetran. The Bigetran is in the United States, they call it Pradaxa. I don't know what they call it in Europe. They call it same Pradaxa. And I don't know, is it available in Libya and what they call it in Libya? I don't know. If somebody from Libya can type the name for the Bigetran in Libya, they have it. So the Bigetran is the one of the earliest used in RELY trial, and the dose are 150, typically 150 twice daily, but sometimes in very risk of bleeding, etc., may reduce to 75. So the patient was started on the Bigetran 150 milligram PO twice daily. Next slide, please. So Mr. MG became more compliant, and now he come to see the patient earlier. It's only 1 year later. He's doing well. His blood pressure is controlled. He's still in atrial fibrillation, and he's doing well. If we go to his profile, Yusuf. So,
Khalid, Fathi, we had a question through Zoom about since the patient has peripheral.
Right, we can come to it later. I think I've seen it, so we can leave it for full formal discussion because it's an interesting question. So Mr. MG's clinical profile, he's 76, and nothing else changed. Everything else has been the same. So, excuse me, at this time, what would you do? Did you check his INR or check his creatinine? Or would you stop the Bigetran since he's doing well, or you check his CBC? So one of these four choices. What test you do on Mr. MG about a year since you started him on the Bigetran at follow-up, or you just stop the Bigetran? It's done well, so you stop the Bigetran. Please go ahead and put your answer in the Facebook page chat, and then we'll give people about 5-10 seconds about which next step would you do. Okay, so Dr. Abdullah Nas, number 2, check his creatinine. Excellent. I don't see any more answers, but that's exactly the right answer. So we know these newer Asian DOACs, especially the Bigetran, these are the ones creatinine clearance exactly. So these are especially the Bigetran is about 80-85% of it is cleared by kidneys, so there will be fluctuation. So in all patients with DOACs, you need to monitor kidney function closely, especially the Bigetran and rivaroxaban, which is Xarelto. These are the ones especially more, but all of them, at least every 6 months, you do a kidney function test on patient. Next slide, please. So I pass to you, Khalid, to summarize the meeting.
Okay, thank you, Fathi. So, so I think the main message from the presentation today that we know that AF is the commonest cardiac arrhythmia, and it depends on the CHA2DS2-VASc score. It can be associated with high risk of stroke and thromboembolism. It's crucial that for all physicians to be familiar with assessing the risk of stroke using CHA2DS2-VASc score, as well as assessing the risk of bleeding using the HAS-BLED score. But the key is not just to assess them at the initial visit, but also to update them frequently, because according to the change in these scores, you may decide to change the way you treat these patients. The mainstay of preventing stroke is the use of anticoagulant. There is obviously now there is less interest and enthusiasm about using antiplatelet in these patients. We know that European guidelines discourage the use of aspirin. American guidelines still keep it as a consideration. Obviously, clopidogrel is no longer a choice for atrial fibrillation patient. Warfarin is still a reasonable choice, but obviously we should be aware of the limitations, specifically the narrow therapeutic range, as Dr. Yusuf Adorat clearly showed that nice slide where any level less than 2 INR, you don't have protection from stroke, and any level above 3 INR, that the benefit of stroke prevention is outweighed by the increased risk of bleeding. And we're also aware of the drug interaction and food interaction. The new medication, they're no longer new. We now call them DOAC. They are very effective. They are favorable in most patients. They have a better risk of stroke prevention with less risk of bleeding. Next slide. So just to recap on the difference between the European and American practice, obviously it's almost the same for most of them. For CHA2DS2-VASc 0, obviously patient does not require any prevention, stroke prevention. Whereas if the patient had CHA2DS2-VASc 1, the European guidelines recommend consideration of anticoagulation, whether is it vitamin K antagonist, such as warfarin or Coumadin, or the DOAC, any of the 4 available in the market. The American guidelines in this group slightly vary, that you may want to consider aspirin, but also still give the option of considering anticoagulant. Clearly for CHA2DS2-VASc 2 and above, the recommendation is to strongly consider anticoagulations, and probably more favorable toward DOAC, obviously, if is it affordable and there is no contraindication. The exception is obviously mechanical valve, where they need to be on warfarin. There is really no evidence yet for use DOAC. Strong evidence, although I am aware of there is some study looking at low-risk mechanical valve, but at present the practice is to use warfarin. Obviously for aortic mitral mechanical valve, your target should be between 2 to 3, whereas for the mitral should be always higher, between 2.5 to 3.5. The other thing which we didn't discuss in details, that for severe renal impairment, especially if your creatinine clearance and eGFR is less than 15, we still give warfarin rather than DOAC. And the other exception also is active advanced cancer. But obviously the practice varies from one region to another, from one country to another, from one continent to another, bearing in mind the cost and the implication of these new drugs, because as is mentioned in the comment, that they are quite expensive. Although there is some concern about antidote and reversible agent for these medication, but now that's no longer a concern because we have antidote available for all DOAC. Next slide. I think now this brings us back to Nancy Fathi, so I'll hand it over back to you.
Okay, so back to this 82-year-old female. She's hypertensive, diabetes. She has paroxysmal atrial fibrillation. So the question is whether you put her on anticoagulation or not. Again, you wait for this very active elderly lady. Is the risk of stroke worse or risk of bleeding worse? Again, I mean, I think now all of us has some good feeling that this lady probably should be on anticoagulation. And because the risk of bleeding is probably lower than the risk of having stroke, which can be debilitated. Of course, you always has to discuss the choices with your patient and take in mind considerations, stuff like affordability of medication, availability, compliance, etc. Well, I think that will conclude this presentation, the symposium, and we will open the floor for some questions. Thank you, everybody, for joining, and we'll wait for some comments.
Fathi, there is a comment from Dr. Abdulwahab Naas about some physicians still use CHAD2 score rather than CHAD-VASc score. Any comment?
Yeah, so in fact, we have a backup slide here. Maybe Yusuf can bring it. So most of the original studies were in fact done on CHAD2 studies. So there were the prospective, like randomized trials, and the risk of stroke was closely related to the CHAD2 as opposed to CHAD2-VASc. And so there's more data, were more concrete with that. So there was some reluctance on the CHAD2-VASc was originated in Europe, right? And so the VASc component, which at the age over 75, the gender, female, and the patient has some vascular disease. So the VASc component was added later, but although it was not randomized, was not the same score used to risk stratify patient in original trials and been adopted lately. So the US adopted the VASc score later, and now it became the only one score to use. So CHADS2 is the original one, but CHADS2-VASc is the most recent one. So some people say if the patient's CHADS2 is 1 or more, and then there's no question. But if the patient's CHADS2 is 1 or less or 0, and then you apply the VASc elements. So the age and yeah. So this maybe the next slide, Yusuf, or slide before this. Yeah, this one here. So if you look at the here is the, if you look at the blue. I don't know if Dr. Naas is watching, but if you look at the blue color, the blue is the CHADS2 and the red is the CHADS2-VASc. And as you can see, the linearity, the correlation between CHADS2, it was more related to the CHADS2 compared to CHADS2-VASc. But today, I mean, all patients, we risk stratify them based on CHADS2-VASc, both, I think, European and American.
I think, Fathi, there is another question from Dr. Ali Al-Maddah about what was the rate control drug used for our second patient. We may need to go to that slide, Yusuf.
What was what, sorry?
Was there a rate control drug medication used for our patient?
There was none for that patient. I think, we didn't want to cover rhythm versus rate control.
Right.
Now, it can affect your decision to start patient anticoagulation or not. That's regardless. Rate versus rhythm control is something you decide based on symptoms.
Yeah, but I think this brings up a very interesting point. Let's say you have a patient and you put them on you choose a, as you know, it's atrial fibrillation, you have a rhythm control, which means you try to keep the patient in sinus rhythm, and you have a rate control, you try to keep the patient in AFib, but the rate is controlled, like below 120 on exertion and maybe 100 on rest. So let's say it doesn't matter if you choose a rate control strategy or rhythm control strategy, doesn't matter whether you put the patient anticoagulation or not. Does the patient's risk change if you're in control and sinus remains sinus rhythm almost all the time or not? Of course, there will be some exceptions. I'm sure clinicians, they may have those patients, they think they've fixed their afibrillation, it's gone completely. But I think the practice, at least the practice I still do, even if the patient is in sinus rhythm, but his CHADS2 risk VASc high, I would still put them on anticoagulation.
I think, yeah, I think the answer to Dr. Al-Maddah is this patient is rate well controlled. Probably that's why the patient not on rate medication. And the focus on today presentation is really on assessing the risk of stroke and on best strategy of stroke prevention. There's another question, Fathi, interesting question from Dr. Hannah Adris about patient had peripheral artery disease, and would you consider adding antiplatelet to anticoagulation in this patient?
Yeah, that's a loaded question. I think the question of antiplatelets and antiplatelets on top of anticoagulants, let's say, I think we can extrapolate the data from, or actually the practice from patients with who had a stent. So you have a patient, you put a stent in this patient for acute coronary syndrome, and the patient has atrial fibrillation, chance to vascular for 3 maybe, and then what you do with this patient, right? And this is a very, of course, a very complex scenario where would you leave the patient on Coumadin or Xarelto or Eliquis, one of those agents, and would you put him on aspirin and Plavix, none of the above? And this is one of those areas I think it's still evolving. There's lots of practice difference. If you look at at least European, currently there was still no clear answer to this, and I think probably 3 or more studies published recently to address this is the West Trial, Redual AFib, and the Pioneer. They try to address this, and the practice is quite variable. In fact, the European, if you let me share my screen, Yusuf, I'll show you a couple of slides. We'll probably, let me see if I can share. I can share a PowerPoint presentation here. Okay, I think I can do it here. Can you see?
Yes.
You see it. Okay, good. So let me just make it big. Is it big enough now?
Yes.
So this is a very complex mechanism scheme about what to do. I think this is extrapolated from the European data. So it tells you what's the patient's risk of stroke, and then what's the patient's risk of bleeding, and you put into the mix is the stent. Does it happen in stable coronary artery disease, which is step number 3, or patient have acute coronary syndrome? Did you put a bare metal stent versus a drug-eluting stent? And you see how many combinations you have. You have plenty of combinations. Very, and again, I mean, these are all based on expert opinion. These are not formally concluded. So choices. This may be, this approach may be probably, I would say that's the closest approach I personally use. And it's again driven from the European guidelines. So if the patient has a PCI, has a stent, and you have 2 risk of bleeding. If the patient risk of bleeding is low to the intermediate, for example, has blood risk is 0 to 2, so you put them on triple therapy for 6 months, no problems, because risk of bleeding is low. And triple therapy, again, debate about which one to choose. I think based on the West trial, you choose, at least what I choose is Coumadin, and I aim for a low therapeutic INR, so INR between 2 to 2.5, as opposed to between 2.5 and 3. So I use a Coumadin with low therapeutic INR, 2 to 2.5. I use a baby aspirin, only 81 milligram or 75 milligrams, and clopidogrel, which is Plavix, as opposed to Berlenta or Effient, which are risk of bleeding is higher. So this is, if somebody has no risk of bleeding, and after 6 months, you can discontinue the aspirin, and you just continue warfarin and Plavix. And after a year, you can then decide what to do with the Plavix according to your type of stents, etc. On the other hand, if the patient's risk of bleeding is high risk of bleeding, means has blood risk 3 or more, and then you may put them on triple therapy for only 1 month, 4 weeks, especially if the patient has a drug-eluting stent. If the patient has a bare metal stent, sometimes you can just go dual therapy after that, but the risk of bleeding is high, so you put them on Coumadin, low therapeutic, 2 to 2.5, Plavix, and aspirin, baby aspirin. And in all of these patients, you have to put them on some proton pump inhibitor. You have to put them on omeprazole or Pepsid or something to prevent bleeding risk in their stomach. So this is for only 4 weeks, and after that, you just switch to dual therapy. Now, this is probably the most practical approach. Now, if you look at, there's multiple data, multiple studies. The bottom line is forget about the aspirin. If you want to drop one of those, triple therapy, and stay on only 2, you can drop the aspirin. Aspirin is the one. These are the main studies addressing this question. There is a Pioneer trial and Redual AFib. Both of them are published, and then both of them were Redual addressed the. I think Redual addressed the Bigetran. Correct me, Khaled. I think
yes.
the Bigetran, right, and Pioneer addressed Xarelto, which is rivaroxaban. But probably the only, and this is a meta-analysis of those trials. So there is a meta-analysis of these trials. Again, it's just a meta-analysis published, I think, last year or the year before. It shows that if you use a dual of the 3 studies, the West, Pioneer, AFib, and Redual, the dual therapy is probably close to be as effective, or maybe better. In terms, this is the risk of, and also risk of bleeding is less. So clearly less bleeding for dual therapy compared to triple therapy, and the benefit is about the same. But again, this was not powered to compare the different agents. In today's practice, we have multiple agents. We have multiple oral anticoagulants, and currently there is this is the ongoing trial, the Augustus Trials. It's probably the largest and the only prospective randomized trial. It will recruit about 4,600 patients from 33 countries, more than 500 sites, and they're going to compare this apixaban to warfarin and aspirin and placebo. So this is going to be a very complex design, but this would be the answer to this question, which we don't know at this time. I think,
but this patient has a right iliac stent, so it's not the PCI. So would you just give aspirin for a few months and then stop the aspirin to keep the patient just warfarin?
Yeah. So if you choose dual therapy, if you want to extrapolate, I don't know if there is any peripheral arterial disease. I don't do lots of peripheral, so I don't know if there is any peripheral arterial disease studies specifically addressing this question. I doubt it. If any of you guys know, probably chime in, or if any of the audience can let us know. But I would do, if I would do anything, I'd probably skip the aspirin, like I said before. I would just keep them on Coumadin and Plavix for the duration of the stent as a dual therapy. After that, and then you can decide whether you're going to continue with the Plavix or not. But I would probably treat them as a coronary stent unless it's different. What would you do, Khaled?
Fathi, I think our practice here in the UK is similar to what you said. Usually, we take into consideration different things, whether it's a drug-eluting stent or bare metal stent. Also the risk of bleeding. But generally, we recommend triple therapy for a minimum of a month. But sometimes we could go up to 3 months. I agree with you. We tend to give aspirin and Plavix. We avoid ticagrelor or prasugrel because there is a higher risk of bleeding. And then we prefer warfarin, but with the new data from the dual PCI, there is increased use of the Bigetran. Some physicians prefer to use the reduced dose of the Bigetran as part of the triple therapy. And also there is some evidence for rivaroxaban, but I agree. Usually after we switch from triple therapy to dual therapy, we always drop the aspirin. So I agree with your message. Forget the aspirin. So if you have to stop anything, it have to be the aspirin. So I think, yeah, I agree. We have a similar practice here.
Great. Do you have any more questions? So, of course, we did not discuss the options of a left atrial closure device or Watchman or Lariat or any of those, which is probably a different topic. But can in two lines, can one of you guys tell us which patient you would probably consider the left atrial closure device?
And patients considered for left atrial closure device would be patients at increased risk of bleeding, a history of GI bleeding or intracranial bleed. Those are the patients that can be considered for left atrial appendage closure. Now, left atrial appendage closure, there's a lot of, I think there's debate because if we look at atrial fibrillation as a local focal electrical issue in the left atrial appendage and the left atrium, and there's increased clot formation in the left atrial appendage, then obviously a closure device is the answer. But there's another school of thought that that AFib is a more systemic disease. Clots can form anywhere in the appendage, anywhere in the left atrium. So systemic anticoagulation should be used. So there's a debate. I'm not sure if we're going to get one day to the point that everyone will get a left atrial appendage closure device, but definitely for those patients who have had a significant GI bleed and they have a high CHA2DS2-VASc score, then left atrial appendage occluder can be helpful. Again, it's new technology. Watchman has been shown to be non-inferior to warfarin, and so that's what most centers use. But there's more things going on with other occluders like Lariat, which is essentially epicardial occluder, not an occluder, but it's like a lasso. It's just closes off the left atrium. And so we'll see what the data would show in the next few years with regards to that. I'm not sure if you have any comments, Khalid, about it also.
Yeah, so just a comment to the audience. So I agree with Yusuf is one general concept is atrial fibrillation is associated with risk of stroke because there is increased risk of developing clot in the left atrial appendage. But we all, I agree with Yusuf that we think AF is more a systemic disease with increased risk of thromboembolism. So there is controversy there whether the left atrial appendage is the main reason for increased risk of stroke in these patients. I think I will consider this option at present for patients who already tried anticoagulation and developed bleeding, or they couldn't take it and they're still at high risk with high CHA2DS2-VASc score. Obviously, there is different options, whether is it surgical excision of left atrial appendage, that's obviously very invasive. But then there is the percutaneous approach, and that can be classified into endocardial or epicardial. So endocardial, you basically place a device, a closure device, to occupy the space and stop clot formation. The epicardial approach, which Yusuf mentioned, is the Lariat, where it is epicardial approach. You go from the pericardium and you take a suture and you ligate the appendage. Obviously, the result, the data is kind of showing it's non-inferior to warfarin, but I am aware of there is a large randomized trial ongoing, so hopefully we'll get more data to support its use. But at present, it has a limited indication, so it's usually for the patient with high risk of bleeding or develop bleeding, or they cannot take anticoagulation and they have a high risk of stroke. Anything else to add, Fathi?
No, I think that's completely. Maybe there may be one of the audience from Libya. I would like to know what are the choices we have back home, what medication, and what's the experience. So there is one of the audience from Libya. I would like to, if you guys can type in the Facebook, but we have somebody with us in the meeting, so I'm see if she can give us some inputs. Give her the mic. Dr. Hanan, you can talk. 1 second here. Let's see if she got a comment about the experience of Libya with medication, and like to know. I don't know if she. Dr. Hanan, you can talk.
Yes.
The mic is
Yeah.
yours. Yeah,
Yeah.
thank you. We can hear you. Yes,
Yeah.
we hear you, Dr. Hanan.
Yeah, I have. I just came to Libya for the last 4 months exactly. Yeah, I was in Australia. My practice mainly in Australia.
Nice, very nice.
Yeah, but I shock here in Libya. There is nothing in the public hospital, and then if you want to prescribe this medication to the patient, it's very expensive, and you know the situation here in Libya is very bad. Yeah, so also the practice here, they don't prescribe it. But they regarding to CHA2DS2-VASc score and this bleeding score, I find a lot of the patients, they have triple. The aspirin, they prescribe aspirin, Blavix in addition to the warfarin, and they don't use this score at all.
Oh, okay. Well, that's a very nice comment.
This is I don't know in Tripoli or in Benghazi, because what I'm now
where
in
where are you, Dr. Hanan? Where are you? Which city?
In Al Bayda, Green Mountain.
Al Bayda, mashallah, that's good.
Nice place, but the hospital is disaster.
Yeah, no, this is fine. That's why we need to know, because we practice outside the country, so we don't know the different practice sets, and probably you brought a first continent. Like we have 3 continents, like Libya, Australia, Europe, North America. So it's good to know the difference.
Yeah, in Australia, just my practice in Australia, just in the cath lab, just coronary angio, but that's it.
Okay. But when you put a patient on a stent, like the discussion of dual.
That's why my question was not regarding to the BCI patient. I know the BCI, and I know a lot of study doing there, and also where I was practicing Liverpool Hospital in Sydney, a lot of trial there in this medication. But my question was in this patient, because he's have peripheral vascular disease. And we know if it's peripheral vascular disease, it is one of the atherosclerotic disease. And I believe this patient will have one sort of the coronary artery disease. So that's why I ask, if you find this patient and you know he have a stent, did you consider aspirin in addition to anticoagulant or no at all?
Yeah, no, that's a good question. And again, I mean, I personally,
I can consider this patient as stable coronary heart disease more, you know. We don't have any angiogram. You know, the AF, one of the presentation for the coronary artery disease.
Right, absolutely. No, I think that's, so which agent is available in Libya? The Bigatran or Rivaroxaban or Eliquis, Apixaban?
Apixaban, and it's bringing usually from Egypt or Tunisia.
Apixaban, which is 5 milligrams twice daily, right? That's an agent.
Yes. Yeah.
Okay. And you said warfarin is still used?
Still used a lot.
A lot. And how from your experience, compliance and people know when to go and check their INR, education about Coumadin in terms of food interaction, drug interaction. Is this something the practitioner back home?
The problem here in Libya, because what I can say, no control. You know, no INR in the hospital. They do it as private, and there is no control in the. It's like a business.
Okay.
You cannot believe in the in INR actually, because I have one patient. He came with the bleeding, and they sent the INR, and it was normal. Then I send it 3 times until I find one lab, they find it is very high.
So even not a consistency of.
Unfortunately, no, there is no one check the lab, you know.
Okay. So how you adjust the dose? Then you put the patient on 5 milligrams.
It's very
of treatment
hard.
and that's it.
It's very hard.
Or,
It's very hard.
so you choose a dose
Very
and you
hard.
keep the patient on it. Yeah.
For
That's-
me,
Can be
to practice
helpful.
here in Libya.
ان شاء الله ربنا يكون في عونك والله نسال الله ان ييسر على الناس
يكون في
وعلى
عونهم
أهلنا.
هم، يكون في عون المرضى
عون.
يعني. إن شاء الله
يكون
يكون في
عون
عون
المرضى
المرضى.
عون الجميع المرضى والاطباء زملائنا غادي اكيد يعني they're struggling with this and it's very I think it's very important to at least educate some of the practitioners about using the risk score for both bleeding and stroke because a patient like this maybe حتى جهات العليا يعني مثلا maybe حتى وزارة الصحة or somebody if people with chest to VASC of maybe 4 or higher they should bring the Eliquis or this medication at least cheaper for them or يعطون يعني promotions to get it easier because they're a high risk of bleeding and they can't have an INR, right? Or high risk of stroke, they can't have an INR. فممكن حتى الحكومة يديروا لهم some sort of promotion or they get the medicine free for them. And maybe because of lack of education about INR, people it's more expensive to do INR. INR is not very consistent, or there's lack of calibration between different labs. So maybe DOAX is the best thing for the country, for everybody.
I hope that.
Fatih, we have a question from Dr. Mohammed Shichat. If these on Facebook, a patient with AFib was on warfarin, now turns sinus. Is there any indication for anticoagulant or not? So it's a paroxysmal AFib patient, sounds like.
Okay, Khalid, or use one of you guys.
Khalid, do you want to address that?
Yes, so a very good question. We get this question quite a lot here from our general practitioner. So essentially is the indication to start or stop anticoagulation is depend on your CHA2DS2-VASc score. So if you have atrial fibrillation and you had symptomatic atrial fibrillation and your CHA2DS2-VASc score is 3, even if you restore sinus rhythm with chemical cardioversion or spontaneous, we decide on continuation of anticoagulation depending on the CHA2DS2-VASc score. Very common question we get even after AFib ablation. So we do AF ablations and then we restore sinus rhythm. So the decision to continue or discontinue anticoagulation depend on the CHA2DS2-VASc score. So if their CHA2DS2-VASc score is 1 or 0, if it's 0, you could potentially stop it. If it's 1, you discuss it with the patient. If it's above 2, we don't. So essentially, to answer your question, it depends on the CHA2DS2-VASc score. Do you have anything to add, Yusuf?
No, I agree. I mean, like you said, basically CHA2DS2-VASc score that would decide whether the patient needs anticoagulation or not.
Yeah. So it's a very common mistake by some physicians that as soon as the patient go into sinus rhythm, whether spontaneously or cardioverted chemically or electrically, they stop anticoagulation. And that's a mistake. We know that the highest risk of developing stroke and thromboembolism is during the conversion from AF to sinus rhythm. So it's crucial to continue anticoagulation and your risk will continue depending on your CHA2DS2-VASc score. So I would recommend that if the CHA2DS2-VASc score is 1 or above to continue anticoagulation.
Yeah. And I'll add that there's hasn't been shown that there's any difference in risk of stroke between paroxysmal and persistent AFib in data. So that's why.
A couple of comments in this regard. I think there's this category of patient who I think neurologists see this more than us. Patient present with what we call cryptogenic stroke. So they present with stroke, and patient has risk factors, but no documentation of IAF whatsoever. Patient in sinus rhythm, and there's no risk of stroke. There's risk of CHA2DS2 is high, but there's no documentation of AFib. And the question is whether this patient has in and out of AFib. And there is a Crystal AF trial. So you implant what they did, they implanted a reveal, like small monitor underneath the skin. And they found about 30% of those patients, they have paroxysmal atrial fibrillation. But you just did not catch it on time. Now, I think this brings another question, which is AFib, does it matter if the patient has AFib or not? If his CHA2DS2 risk VASc is high, regardless, would you just put them on anticoagulation or not? And I think there are some studies looking at this. I'm not up to date on this, how they use it. Do you know any progress on those? I know there's people looking at, take AF, doesn't matter if you have AFib or not, if you have CHAD2 risk VASC is high. So I think people looking at trying to see if there's stroke reduction regardless of presence of AFib.
Yeah, the problem with those studies is the incidence of stroke. You have to have a huge number of patients to prevent stroke. You have to have 2 arms, give an intervention, and then compare. So those studies have limitations. I came across one study in HRS. I think they had some preliminary data, but the problem, there's risk of bleeding. So if you treat on a large, I mean, if it's going to be a population-wide treatment based on CHAD's VASC score, there's going to be a lot of issues, I think. I'm not sure if it's going to be practical even, and there's nothing that I came across, the definitive study that showed benefit. I'm not sure, Khalid, do you have any comments about this?
Yeah, so this is, Fatih, this is very controversial subject. About cryptogenic stroke, especially if they develop a stroke, another stroke despite antiplatelets. So there is physicians argue that is it that we have atrial fibrillation, we just didn't pick it up on monitoring. So there is a strong increase in physician using longer term monitor like loop recorder. The difficulty we have is there is a lot of study shows that even if you have AF picked up on a monitor and it's not symptomatic and less than 24 hours, there is the ACERT trial showed that your risk of stroke only increase if you have AF more than 24 hours. I'm talking about asymptomatic AF picked up on a monitor, which I presume this will apply for the cryptogenic stroke. So it's a difficult topic. At the moment, we have lack of data to support which way we should go. However, I do agree that all cryptogenic stroke with high CHAD-VASC score should be extensively monitored and considered for potentially loop recorder if it's affordable to see whether or not we pick up AF. But then the question is, how long is the AF? And that's a question need to be answered still. So it's a difficult topic.
So let me put this question. So if you have someone with a pacemaker and you detect AFib, the AFib is 8 minutes. I'm going to use 8 minutes. Would you start anticoagulation or not?
So that's a very good question. So according to the latest data is, if they are symptomatic, then yes. If they are asymptomatic, then there is debate. Some people used to use 6 minutes as cutoff, but now the data suggests it's really more than 24 hours. So if the patient is asymptomatic and their AF period is less than 24 hours and their CHAD-VASC score is low, then the answer is no.
So why the symptoms? If the patient is symptomatic, would it increase the chance of stroke?
Apparently, yeah. I don't know.
Yeah. So I came across a Japanese study. It's an in vitro study that showed that actually it has to be in vivo. I think it was an I think what they did, they drew blood markers from patients who have AFib, and they correlated with the onset of AFib, what time the AFib started, and clot formation, thrombosis actually. Median time to thrombosis was about 12 hours from onset of AFib. So definitely 6 minutes or 10 minutes or even 3 hours from a physiological standpoint, it may not increase risk of thrombosis, but who knows?
Exactly.
That's the thing. If a stroke happens, it's disabling, and that's the thing. If someone has AFib and they have high CHAD-VASC score, regardless if they're symptomatic or not, even if it was like 8 or 9 minutes, I think I would start anticoagulation.
I think I agree. At the moment, I discuss it with the patient. And if they are asymptomatic, so essentially this is what we call it subclinical AF. So someone had the device, you picked it up by a chance, you find that they're in AF, they're not feeling it. So I always assess their CHA2DS2-VASc score, discuss with the patient, explain there is lack of evidence, but it's as a physician, I agree with you. If the CHA2DS2-VASc score is high, I'll probably be more considering anticoagulation. But the guidelines, the European guidelines suggest that depending on the CHA2DS2-VASc score, if it's more than 24 hours, even asymptomatic, you start anticoagulation. If it's less than 24 hours, if the CHA2DS2-VASc score is high, you discuss with the patient. Anything to add, Fathi?
No, I totally agree. I think just before we close, I may just throw in a scenario where the patient is already on one oral anticoagulant, and let's say the patient is already on Dabigatran, and then they come with a TIA, with a stroke. So what would you do at this time? So somebody in Dabigatran, of course, Dabigatran, we don't measure INR for it, and the patient comes with a TIA. So what would you do at this time? Do you switch into something else? Do you? So what would you do? Let me ask you, Khalid or Yusuf, just to comment.
Go ahead, Khalid. Go ahead first.
Okay. So Fathi depend on the patient characteristic and the dose of the Dabigatran. Is he on 115 or 150 BD?
Let's say 150 in the maximum dose.
Okay. As from a physiological point of view and looking at the data and comparison, I know that the Dabigatran act on the last step of the coagulation cascade, which is a thrombin. So physiologically it makes sense. It's the most potent anticoagulant, but there is no evidence to support that. So if I have a TIA on the Dabigatran, then I will probably, instead of switching to another DOAC, I'll probably go for a warfarin with slightly higher INR target. That will be my approach, provided I feel it's safe. Obviously, it depends on the patient characteristic, whether he's happy for warfarin. But I would personally not switch to another DOAC. I'll probably switch to warfarin with slightly higher INR target.
Okay. So my comment is that not all strokes are caused by AFib. So is anticoagulants 100% protective against stroke? The answer is no. You always come across those patients who, despite being compliant with anticoagulants, they have a stroke. I had a case before who was really on Pradaxa and had a stroke. Discussed with the clinical pharmacist, and we decided to put him on a different agent, different mechanism, factor 10 inhibitor. So we chose apixaban. We know that apixaban, even based on the slides that Khalid showed, that it's better than the others. Actually, if you look at stroke prevention and thromboembolic events prevention, it may be better. And so we chose apixaban for that patient.
Yusuf, can I just correct you there? Sorry. The only DOAC which shows clearly superior in stroke prevention, clearly superior, is the higher dose of the Dabigatran.
Dabigatran, yes, 150.
That's the only one, and physiologically that makes sense. Why? Because the Dabigatran acts on the last step in the coagulation cascade, whereas all other NOAC, even the highest dose, they're not statistically superior. Whereas the Dabigatran 150 is the only one. So this is why specifically Fathi's question was very difficult. If it was another DOAC, I'll probably move to the Dabigatran 150 BD. But because it's Dabigatran, and I think this happens recently in our hospital, we switched to warfarin with higher INR target. Fathi, what would you do?
Well, that's a tough question, Khalid. I think the concept of escalation or de-escalation of different oral anticoagulants or switching between one category and another, I don't think there's enough data to give us the right answer what we do. I don't know the answer. Let me put it this way. And I think day to day, you just check to see the patient's characteristics, affordability, and other things. But it's one of those tough scenarios. That's why I wanted to know what people would do this kind of scenario. I think there's a question from Dr. Muhammad Shadshad. It's a very interesting question. I'm not sure if I understood it, but let me read it for you, Khalid or Yusuf, and, if you can answer. So Muhammad said, this patient I was talking about was having a CHADS-2 VASC of 3, including CHF, hypertension, and diabetes. A score of 3 now, the score is 1. So according to the study, his use of anticoagulant is debatable, meaning 2 scores are improved. And I assume he meant his heart failure. So the patient has diabetes, hypertension, and CHF, so 3 based on CHADS-2 VASC, and 2 of them are improved. And I don't know what Dr. Muhammad means by improved. Means diabetes is under control, or the blood pressure is under control, or heart failure is under control. So 2 of these 3 has improved. So now the patient is in the office, and his sugar is nice, his blood pressure is nice. Would you downgrade him to CHADS score of 1, or he's still 3? I think this would be the question. In which case he changed whether you give him anticoagulant or not. You want to tackle it, Khalid?
Yes, I think if the patient is diabetic or hypertensive on treatment and is controlled, they still class as fast. So they still class. So his CHADS score is still 3. So yes, the straight answer to your question is yes. I'll continue anticoagulation, even if the hypertension is well controlled, even if the diabetes is well controlled, even if the patient go to sinus rhythm. I can't emphasize this message enough.
Nice.
If the patient go to sinus rhythm, or their diabetes is controlled, or hypertension is controlled, they still need anticoagulation. But other thing, there is a very nice topic which I'm glad Dr. Abdul Wahab al-Naas highlighted, because I really want to talk about it today. Is there is major concern about the use of low-dose NOAC, specifically the apixaban. This is major concern. I know about what Dr. Abdul Wahab Naas is referring to. There is a recent meta-analysis.
Can you, Khalid, sorry, so can you state Dr. Naas's question?
So Dr. Naas's question is, there is concern about the use of low-dose apixaban, 2.5 BD. And this concern is very valid. This is because apixaban, a reduced dose of 2.5, was not well represented in the major trial. It was less than 5% of the population in the major trial were on this dose, which only was around 400 patients. So you cannot make any conclusion from a small number of these patients. More importantly, there is a recent meta-analysis suggests that there is increased risk of stroke on the low dose of apixaban. So our practice in the UK here is a full dose of apixaban 5 BD is an excellent choice. However, I discourage the use of the low dose apixaban because the data is not convincing, and there is concern about increased risk of stroke. And I think there is a nice slide which I didn't have the chance to present it today. It shows that the Bigatran, the RELY trial, there is almost 50% of the population on the full dose and 50% on the reduced dose. So it's a good representation. Whereas the apixaban, there is less than 5% on the low dose. So a very valid point, Dr. Abdul Wahab. I agree with you. I personally prescribe a lot of apixaban 5 PD, but if I feel the patient is at high risk and require a reduced dose, the only reduced dose I avoid is the apixaban 2.5 BD. And I don't know about you, Fathi, and Yusuf, what is your experience?
Do you have a comment, Yusuf? So, Yusuf, you are muted, so I can't hear you. So, Khalid, let me place the devil's advocate here.
Yeah.
So there is a if let's say you have a patient who has his hazard risk is high,
Yeah.
So it has the bleeding risk is high. And then the patient have a bleeding event, let's say massive GI bleed, but his CHADS2 risk is 4 or 5 or 6. So high risk of stroke, but devolved GI bleed. Let's say he devolved GI bleed on Coumadin. Okay. So I want to put him on an agent to prevent stroke, but has the least risk of bleed.
Yes.
So we have a study addressed this patient in only one agent, right? It's the Averroes trial, right? So Averroes trial is the one they took patients who cannot take warfarin and put them on aspirin only or apixaban only. And at the end of the day, they find that apixaban has similar risk of bleeding as the aspirin. So apixaban is not as high risk of bleeding as the aspirin, but it prevents stroke better than aspirin. So this was the Averroes trial. So to bring your point, I think the apixaban may be not the best subtherapeutic at 2.5 or less, or maybe is not enough, but it's maybe the agent. If you have somebody who's very fragile, the risk of bleeding is high, this is the one I would pick and choose. For those who I want to put an anticoagulant, but their risk of bleeding is very high. See what I'm saying?
If you give 5 BD, Fathi, I agree.
5, yeah, no, 5. I'm talking about 5.
Oh, no, I don't disagree with 5 BD.
Yes, 5 milligrams.
Yeah, I think if I have a patient with GI bleeding, I would recommend apixaban 5 BD. However, if I have a patient with high CHAD-VAS score and has a GI bleed, and I see them on apixaban 2.5, I will change it. So I think my comment is very clear, is apixaban 5 BD is an excellent agent. The apixaban 2.5, there is no enough data to support it prevents stroke, and there is major concern from meta-analysis recently. There is increased risk of stroke on 2.5. So I think for the GI patient, a GI bleeding patient, apixaban is a good choice, but the 5 BD, not the 2.5 BD.
Right. Although the label of apixaban, Khalid, as you know, they give you 3 criteria. If the patient has 2, you cut it back to 2.5. So the patient older than 80 years old, if the body weight less than 60 kgs, or creatinine clearance, creatinine, I think the actual creatinine, not creatinine clearance, more than 1.6 or 1.5, I forgot.
1.5.
1.5. So if creatinine is more than 1.5, if the body weight less than 60 or the patient is older than 80, so you cut it back to 2.5. This is based on the FDA approved label. So would you use a 2.5 in that patient, Khalid, or you still use 5?
Never. For that
Okay.
patient, for that, there is a really nice meta-analysis. So Fathi, so if you look at the evidence of the 2.5 from the major trial, it's based on less than 5% of the population. I could tell you the exact number. It's 449 patients.
Right.
This is a major debate in the UK here. There is increased awareness of the risk associated with the low dose of apixaban. There is no doubt the full dose apixaban 5 BD is the only DOAC is associated with improvement in mortality. It's the best NOAC for patient with GI bleed. But this is the full dose.
Right.
The low dose, I will be honest with you, Fathi, is my personal practice. I will never ever use the low dose apixaban.
Okay. So but somebody with that profile, you put them on something different, right?
Absolutely. Another reduced dose agent.
Right.
Yeah.
Right. I think something else to mention, and on top of this, also patient with intracranial bleed, patient who have previous intracranial bleed, I think apixaban is, if you want to choose one of those, somebody has CHADS2 has risk of high and then have history of intracranial bleed. I think the lowest one has that is the apixaban. Lowest risk of intracranial bleed among all of these agents.
Yeah. I think this is, Fathi, another interesting topic, which probably, I think the message from this symposium is that all DOAC has shown to be effective and probably favorable over warfarin. All are being approved by FDA and ESC in Europe. So they all have different role and independent physician experience and preference. But there is some variations. I personally, I don't know, Fathi, if you I usually, when I consider patient for DOAC, I give the patient the choice. I start with the BD versus once a day because of compliance. Then food interaction. I find that recently there is an increased awareness of patient aware that, especially for example, rivaroxaban, you have to take it with food, otherwise it will not well be absorbed. Then there is also the risk of interaction. For example, there is some drug interact with specific DOAC where it doesn't interact with the others. So there's different factors you need to take into account. Again, another topic which we didn't cover, will probably is beyond the scope of today symposium, is renal failure and what do we do with these patients. That's another topic.
Yeah, maybe a topic for another day. And just one final comment, I think, before we conclude the meeting. We're about the 2-hour marker here. The risk, back to the question asked by Dr. Muhammad Chachap earlier, the diabetes, hypertension, and heart failure. So these, if the patient has them, does not change even if they are not controlled when you calculate the CHA2-VASc. However, as far as the blood pressure goes, when you calculate the Hess blood risk score, it changes. If the blood pressure is 160 or higher, and then the risk is high. But if you get the patient's blood pressure under control, and the patient's blood pressure is not anymore more than 160 in a consistent matter, and then your risk of bleeding comes down. So I think this is important to delineate. So any other more comments before we conclude, Khalid or Yusuf? Yusuf? You're muted, Yusuf, so I can't hear you.
Yeah, nothing to add. It's been a really good webinar today. Thanks for all who participated, and thanks also to Dr. Hanan who talked about the situation in Libya. Floor is yours.
Fathi, I think, thank you very much everyone for attending today. I think there is a request from Dr. Adris that if we could organize another symposium to discuss rate versus rhythm strategy for management of atrial fibrillation. So hopefully our next webinar, we will be discussing that, and we will keep you posted through eCardia Facebook page. Thank you everyone for attending. I don't know, Fathi, if you want to conclude the meeting.
Yeah, so just note this one thing you can notice, that we have a meeting about atrial fibrillation. There is not a single EKG, right? In the whole presentation, we didn't see a single EKG. But and this maybe suggests that maybe next time we'll talk about rate and rhythm control. Again, thank you so much for everybody for attending and for your participating in this seminar. And we'll see you, inshallah, at the next time. Wassalamu alaikum wa rahmatullahi wa barakatuh.